All right then, we're ready to start. So hello everyone and welcome to this webinar. My name is Ariella Shoham. I'm a Vice President Marketing at Aidoc and I will be your host today. This is Aidoc's third quarterly Ask the Experts webinar where we invite users of AI in clinical practice to join us and share their story. I'm extremely excited to have Australian group Global Diagnostics with us today. We have Dr. Nazar Bokani, Clinical Director at Global Diagnostics, and Paul McCrow, General Manager. And we also have Tom Valent, Aidoc's Vice President of Business Development. Hello, hello all. I just want to say hi and see that you're not muted. Let me see how you are.
Hi there. Hi everyone.
Hi, Dr. Bokani.
Hi, this is Tom. Good evening, good morning, good afternoon, wherever you are in the world.
Hi, Paul McCrow. Welcome.
Thank you, guys. So just before we begin, I just want to let you have a look at the agenda, but let me just go through some house items. You are all on mute, but you can communicate with us through the chat or QA button on the bottom of your screen. We'll be running about 35 minutes and we will open for a chat QA at the end, but please feel free to submit your questions throughout and I'll be able to address them as we go along. So without further ado, let me hand over to, or let me take the next slide over to Tom to just give you a quick introduction to Aidoc. So over to you, Tom.
Thanks, team. So after we've demonstrated that, I'll take a minute or so to just give an overview of Aidoc for those that haven't heard of us or haven't heard enough about us. And I'll also connect it to the general situation in the quickly emerging AI market in radiology. So Aidoc is one of the leaders in this space, and the reason we say that is because, one, we are regulatory cleared. From a US perspective, we already have 3 FDA clearances, and likewise in Australia, as well as other regions around the world. Today, at the moment, radiologists use us clinically in their workflow, in their day-to-day, at over 200 hospitals across the world, as well as private radiology groups such as GDA, and we'll get into that in a minute. We've already analyzed over 2 million exams in production just with the specific AI modules of ours. So these hospitals obviously have a much higher volume, but we've analyzed a portion of theirs that is relevant for our specific critical findings. And there are there are exactly 14 papers and clinical studies published by various institutions across the world demonstrating our impact. And when I say impact, I'm not talking about sensitivity specificity, but more driven on KPIs and key metrics that are relevant to those institutions, such as length of stay, quality, turnaround time, etc. So the point of this slide is to basically make it quite clear that AI is real, it's happening, your peers or potentially you are using it already in production nowadays. And yes, there's a lot of information out there. It's quite difficult to understand who are the more mature players and what their value propositions are. And one of the objectives of today's presentation is to give you more information on that topic and educate you on the feasibility and the value of such AI solutions.
Thank you, Tom. I'll let Paul continue. Thank you.
Thanks, Ariella. So to go forward, this slide and the next few slides are really about giving you a context of Global Diagnostics. I expect that most of you don't know who we are, so to give you a rounding of how AI helps us and the decision that we made around how to implement and in choosing a partner such as Aidoc. So to give you some background, Global Diagnostics was established in 1998 In those days, it had a different name. We've had a couple of different names over time, still the same company. In 2015, we became wholly owned by a Victorian group and became part of what is now Global Diagnostics, who are the third largest diagnostic imaging company in Australia and New Zealand. We are a very patient-centric practice. We're committed to innovation and technology, and I think we are one of the earliest adopters of AI in Australia. To give you an idea of what GDA is, we're a privately run practice, though we service a lot of public hospitals and private hospitals, as well as private clinics. Because of our public hospital work, we are 24/7, 365 days a year. We report this year approximately 400,000 cases. And it is quite a complex and varied case mix. And because we're within hospitals, we do have contracted turnaround times. So we have to deliver our reports, at least 90% of our reports, within a clearly defined timeline. We have 48 radiologists based in Australia and across the world, actually. So we are very much global by name and global by geography and coverage. So to give you an idea of how big GDA is, or how big a territory we cover, this is a map of Western Australia. We cover 2 million square kilometres of Western Australia. And just to put that in context for those from overseas, this is about 3 times the size of Texas, or about 20% of the size of Europe. For the Aussies on the call, this is an area bigger than Queensland, or bigger than New South Wales, Victoria, and South Australia combined. So within those territories, we have 53 hospitals across a vast area of Western Australia. So our decision to choose an AI partner, I will talk about a little bit later in the presentation. To give you an idea of our ecosystem and the way we operate, like all radiology departments, more data, more data, more data. And of course, with that, radiologists have to process more data and deliver reports and work their way through that. As you saw on that map, 2 million square kilometres is a very, very large area. We've got a large geographic spread. And some of these are the most remote communities in Australia, if not the world. So the pathology presentations are extremely diverse. Within that, the quality or level of scanners is quite varied as well, anywhere from a 16 slice CT scanner all the way through to top of the line Canon 320 slice Genesis. Add to that, like every country in the world, the further you get from a capital city, the harder the infrastructure gets, the harder the network speed gets. So this is the complexities that we've had across our business, and something that Aidoc had to work within, because we can't change nearly any of those criteria. So when we were looking at these variabilities, Aidoc had to work within those. So they had to assist us in prioritising the critical cases, the ones that had to be at the top of the reporting list. We had to work 24 hours a day because that's how we work. And they had to add real value to patient outcomes. As I said before, we're a very patient-centric practice, and we're very much about improving patient outcomes irrespective of location. Within that, we had to keep the radiologist at the centre of the diagnosis. So this was the challenge that Global Diagnostics and our parent company, Integral, had in selecting an AI partner such as Aidoc.
Thank you, Paul. So I'm going to hand it over to Dr. Bokani, because I think the audience are probably interested to see how this actually looks. So let me have you hand over the sharing to, there we go. I can see your screen, Dr. Bokani. So please walk us through
yes,
from the top. Thank you.
Thank you, Ariella. Thank you, Tom, and thank you, Paul. And hello, everyone. My name is Nazar Bokani. I'm a consultant radiologist, and I'm the clinical director of GDA. As Paul has nicely mentioned and outlined for us, we do cover a quite big geographical area, and that comes with a lot of logistic and operational challenges. And from the get-go, we were quite keen to provide the top service to our patients, regardless how far or how remote the locations are they're coming from. And we, when we started looking at the modules we have within Aidoc, we've decided to go with those three modules you'll see here on the screen. So number one is the one that is related to intracerebral hemorrhage for the detection of cerebral bleeds. And the second one is the one related to Cspine fractures. And the third one is for the detection of acute pulmonary embolism. Reason being we've decided to go with this is, of course, the acuity of these presentations and the challenges that they give us when we try to diagnose them in a timely manner. So the way we use Aidoc is basically Aidoc is on all the time. Aidoc runs on the background. So just to give you an example, we do scan patients in an inpatient or an outpatient capacity, and by the time they get the scan done, Aidoc is already starting the process of analyzing the exams. And when it detects one of the three pathologies I've just mentioned, it will prioritize this case as a high priority or clinically urgent case that needs attention and needs assessment and swift reporting and notification, of course, of any abnormalities to the referring doctors. So for us, is it a way of time management and a way of putting a case higher up on my list? So it would trigger me to look into that case, and I will show you some examples where this is really very important. This is a snapshot of our workstation, basically, the software we use for reporting our risk system. This is our Comrade system, and as you can see in the left upper corner, there are cases highlighted in number 1 in red color. This means this is a high priority case. We need to look at it and report it and communicate the findings in less than 2 hours time. This is an important part, and which Aidoc is helping us enormously. And we are in the process of fine-tuning this prioritization of cases. For the time being, the way I use Aidoc is as a widget running on the background. This is a very good example of the importance of having the system running on the background. This is a case of a patient presented to ED with clinical suspicion of pulmonary embolism. And when the reporting, that was in the ramp-up period when we were introducing Aidoc and integrating it into our workflows. The reporting radiologist, unfortunately, wasn't able to detect a small pulmonary embolism in one of the branches of the left pulmonary artery into the left lower lobe. And in hindsight, when we look at it, and when the case was run through Aidoc, Aidoc was able to detect a small pulmonary embolism in this patient. And luckily, we were able to report that again to the referring doctors, and they were able to start treatment. The way I've chosen for the system to operate is, this is a screen next to my workstation, next to my diagnostic screens. The widget, the Aidoc widget, this is the left lower corner here. You see this A in orange color. This is the Aidoc. It tells me there is a case has been flagged by Aidoc. And when I click on that case, it's showing me immediately in one snapshot the pathology that is related to that. With this case is, of course, a cerebral hemorrhage. And the list of the cases will appear if I click on that widget. And it shows me, for example, this is a case related to the pulmonary embolism module. This is a case related to the cerebral hemorrhage module. And there is another one related to Cspine fractures. So by looking at the case in one snapshot, I can see whether this is an urgent finding or not. At the same time, because we are using voice recognition as well in our reporting on the system, I can see immediately when I just hover over this case here and see there is an impression, there is a comment and conclusion attached to that. That means one of my colleagues has looked at the case and has issued a report. So I know exactly what has happened with the case and what is the finding and whether the case has been dealt with properly or not. So from a quality assurance and from a quality perspective, it's really very important because it tells me exactly what happened with the case. And I would like to share with you another case. It's quite important, I think, to show the accuracy of the diagnosis. This is a patient, a male patient, 73-year-old, presenting with shortness of breath and a history of DVT. So there is a high likelihood of finding pulmonary embolism in this patient. Again, this was one of the initial scans done on the system when we were introducing Aidoc, and unfortunately the reporting radiologist was unable to see this tiny embolus in the pulmonary artery branch to the right lower lobe, while this has been depicted and picked up quite clearly and nicely by Aidoc. And because of that, we were immediately able to pick up the pathology and contact the reporting radiologist and the referring physician and tell them there is a positive finding which needs and requires urgent attendance and management. Another good example of how Aidoc can be helpful really is in this case of a 77 female patient who presented after a fall. She hit her head and she was confused. And as you can see, there is a nice depiction here of a parafulcine hemorrhage, which has been detected clearly. And also this case, with the help of Aidoc, we were quite quick and swift in reporting the findings back into the hospital. And that was one of the remote sites as well, which means the patient has traveled for quite a fair bit of time to get to the hospital. So by the time we get them and on the scanner, we immediately, basically within minutes, we can report these findings immediately to the emergency department. So basically it is impacting our workflows and it is impacting the way we interact with our patients as with our referring doctors. Another example of Cspine fracture, again, a trauma patient who presented to ED. As you can see, there's a vertical fracture running in the anterior aspect of the C1 vertebral body, which was clearly depicted, and that required, of course, referral to a tertiary center. So it impacts the way we deal with our patients, the speed with which we assess our patients, the priority of the exams, and the impact. I think the most important one is on the outcome of what we're doing, and that reflects itself in a better service to our patients and a timely, let's say, way of dealing with findings and with urgent findings like this one. To give you an example, this is the number of cases that run through Aidoc each month. On average, we do about 1,800 cases, and the bulk of these cases would be CT brains for the detection of hemorrhage or other acute findings. And the other one is, of course, for C-spine fractures and pulmonary embolism. And on average, there will be about 112 cases prioritized by Aidoc, and we are at a stage now where there is almost 100% user engagement in Aidoc from our radiologist. Back to you, Ariella.
Thank you, Dr. Bokani. Let me just ping over a question that came up while actually I'm going to ask Paul to share his screen again because I've a problem for some reason on my end. But maybe Dr. Bokani, can you share how the acceptance by the other RADs on your team evolved along the journey?
Yeah. I'll be quite honest with you. When we started looking at it, there was a bit of apprehension, I would call it, a bit of an anxiety in the group. And there was a bit of fear that Aidoc is going to replace us. Aidoc is going to take our jobs, and we will be basically without a job in a few weeks' time. But luckily, when we were discussing things and the way we've adapted the system, it is working with us rather than working instead of us. Aidoc is helping us as an additional, I would say, safety net out there that looks at the exams within minutes and prioritize them and put them up on my list. And in the end, I am in the driver's seat. I am the one who decides on what is going on here, and is there any reason for escalating things or addressing things in an acute manner or not. So it's not replacing me. I would say it's helping me, and that sense of this is something that is really helping us rather than harming us infiltrated into the group actually over the few weeks from the start when we started using it, and now is just an integral part of our work model, I would say.
Thank you, Dr. Bokani. And you were just, I'm just going to ask you, there's another question coming up, so I just want to ask you now as I still have you.
Yeah, sure. Sure.
And then you're talking about emergency cases. There's a question about outpatient as well. So do you see value in outpatient? Any
Correct. So as we mentioned in the start of this webinar, we do cover a huge radiological footprint in Australia. So that means we can't really provide a radiologist on site in each of these locations. That means if there is there are some regional hospitals with busy ED departments where the patients come in and they get scanned, but there isn't really a radiologist on site. So here is I think the value of having a system running on the background that basically scans and looks through these emergency exams and tell me if there's anything out there that requires really urgent attendance. And I'll give you one example. In the first week we started the use of Aidoc, there was a patient who traveled for about 3 hours to get to one of our regional hospitals, and he got scanned. But with all due respect, the technicians in the end are not doctors, they are not radiologists, they won't be able to see some subtle findings. So the patient was scanned, but there was a cerebral hemorrhage. The technician sent the patient back home, but luckily within a few minutes, because Aidoc was running on the background, the case has been escalated, and the radiologist remotely looked at it and saw the bleeding and called the department, and we managed to basically catch the patient in the parking area before he jumps into his car and go back home, and send him to ED with an acute cerebral hemorrhage.
That's a fantastic story. Thank you, Dr. Browning. Well, it's a good ending.
Good ending, absolutely, yeah.
Thank you. Okay, I'm handing over the speaking to Tom. I guess we've sort of heard this in use, and Paul gave us an intro to the general framework of a decision to join an AI company. Maybe Tom, you can give us sort of. We set out to this year with some milestones, and maybe you can sort of share our thought process, what we wanted to achieve, sort of to give some context from where we are today.
Definitely. Thank you, Ariella, and thank you, Dr. Bokani. Those were some fascinating use cases, and I'm glad to hear and honestly to even understand them better than in our past conversations. So zooming out a bit, in terms of 2019 and the AI space, this year we put a lot of focus on proving the actual clinical benefit, because at the end of the day, early adopters, and now as we're passing the early adoption phase and reaching the mass of the market, the leadership of hospitals, of private radiology groups, of providers in general, what they're really asking themselves is, okay, AI seems like an exciting technology, but how mature is it, and what is the actual value to my institution? So our focus in 2019 was on taking AI to the next step of its maturity, meaning moving it from a product with metrics that are more technically driven, such as sensitivity and specificity, to a product or a solution with clear benefits to the provider in general. And what I mean by that is showing how the fact that the system is accurate and on time and running in the background, how that ends up leading to shorter turnaround times for the cases where time matters most. Just like that patient in the parking spot before he went home, and afterwards it would be much more difficult to get a hold of him or her and to treat him. So showing how we improve turnaround time, how that leads to better patient management and outcomes and earlier care. Showing how those clinical benefits lead to shorter length of stay for providers in a value-based reimbursement system, and showing how also from a radiologist perspective, how we're adding value in making their workflow more efficient and augmenting them also from a quality perspective. Just like the couple of examples that Dr. Bokani shared, we get a lot of feedback from radiologists knowing that while they're in the driver's seat, it's quite assuring to know that there's another safety net out there, and that it helps to provide them with that clinical context of which cases we flagged for those specific critical findings, where overlooking them can, in certain cases, even mean life or death. And that's true whether it's an emergency case where the prevalence is higher. However, of course, still most of the ED cases in general do not have such critical findings, so the radiologist could still be surprised by them. Or outpatient cases where the prevalence is lower, but we still see those cases with, for example, an oncology outpatient getting his or her third chest with contrast CT study. And in that third exam, there was a pulmonary embolism. And that's a case that otherwise without us could wait hours, if not days, in the bottom of the work list. And we can help there prioritize that case and also decrease the chance of the PE being overlooked because it was not the objective of the study and it wasn't in focus. So that's point number one. And I believe that also connects to point number two. And also Dr. Bokani mentioned how his group went through that process during the onboarding phase. Really the point is to clarify the status of AI, its capabilities, as well as its limitations, and how it really augments the radiologist, and it's not replacing the radiologist. In fact, I would say the opposite. Radiologists with AI are going to replace radiologists without AI because it's becoming the standard, thanks to early adopters who really put their focus on providing better care to their patients, such as Global Diagnostics. And point number three is the regulatory process, which is almost a natural result of point number one and point number two. And that is, as we have more and more robust data proving the value of AI as well as its safety, that enables us to continue expanding our regulatory approvals. And that's how we've already reached the point where today we have 3 FDA cleared products, while in general, the market is in its early days and not many companies have, or new age AI companies have FDA clearances at all, because obviously it's quite a difficult process to go through. But really from our perspective, the milestone was to reach multiple FDA clearances and also to prove our ability to continue that pipeline and pace, because at the end of the day, even though we already have 3 FDA cleared products that are used clinically across the world, the potential is endless, right? Because there are hundreds, if not thousands, of potential pathologies and even more use cases. And what we hear from visionary groups like GDA is they would like to tie AI to their mid to long-term strategy, and they want to understand from AI providers such as ourselves what our vision is and what our roadmap is, and that enables them to be assured that when picking a partner like us, it's not just about today, it's also about tomorrow, and that tomorrow supports their strategy in their clinical settings.
Thank you, Tom. And that's a good segue to have Paul share your vision, your group's vision. I'll let you flip through the next slide.
Thanks, Ariella. Yeah, so I guess from our perspective, what's our vision going forwards with AI? For us, it's really around building on what we've already done. So as Nazar has spoken around, there was some resistance amongst our radiologists, but our focus wasn't about taking away the role of the radiologist. It was really about adding another element or another tool to assist them and maintaining them in the center. The algorithms that we've used so far certainly does that. And for us, if we take the example of the cerebral hemorrhage, We're getting AI results flagged to our radiologists within 3 minutes of us receiving the images. That's under 3 minutes that it's flagged on the widget, as Nazar showed, where our doctors can make a meaningful difference in a condition where time matters. For us, it's really around looking at how we can develop those tools that we've already got and make them better. So that's one of our focus for the next year. We don't want to stop with just those 3, and we're working on at least one more at the moment, but we're looking for new algorithms. We're looking for what will work across our business, but also what's the clinical need? Where can we see AI adding value, both from clinical need, but also referrer feedback. And for us to go on our journey by ourselves would be suicide. We actually need to listen to those that it matters most to, which is the referrers who are treating the patients after our diagnosis. So really it is about listening to the wider community as to what and how we shape this product. The other is around working with industry and the college. So our college here is RANZCR, who released AI guidelines a few weeks ago, all of which we comply with, but really it's around working with industry to make sure that where AI goes, we're in the driver's seat and work with someone such as Aidoc to shape how that looks going forward. So for us, choosing Aidoc as a partner, and also perhaps for you guys listening, it's really around why would you go down this path? What are the questions that you would want to ask? What sort of organisation would you want to work with? From our side, it was really around a partnership. It wasn't about a single transaction. It wasn't about, we are going to buy this product, thank you very much. It was really around finding someone that we can partner with, that we can work with, that we can develop with, that we can have input with, that we can have a long-term relationship to develop AI and a product that works for our business. And I guess as doing so, have an impact on patients' lives and industry. For us, everything that we do in our business is very patient-centric. If this didn't have an effect on patient outcome, we wouldn't continue. The fact that we can turn a CT brain around in 3 minutes with a positive diagnosis, escalate it and catch the patient in the car park before they take that 3-hour drive home, that's affecting patient outcome. We need a support network. Buying a great product is only the first part in anything. Having a support network, a team of people that we can call when we need them, having a dedicated customer success manager, someone that we work with, we build a relationship, we have feedback with, we are able to develop the product that works for us, that helps. It's key. Understanding a roadmap, and to be honest, we're at the start of this journey, as we all are with AI. Having that clear roadmap of where we want to go and having continuous delivery of newer solutions and working with a partner such as Aidoc is key. Now, I don't know, honestly, where AI is going to go, but I know that our patients now are benefiting from us using AI and using Aidoc. The complexity of the installation in WA for Global Diagnostics, I don't think Aidoc really understood how complex we were when they first started talking to us, but it has, from almost day one, far exceeded our expectations. So if you are thinking about where you want to go with AI, have a think about how it will drive value for your patients, how to work with your radiologists around delivering that, keeping the radiologists at the centre of it.
Thank you, Paul. Thank you so much. We have our question slide coming up, even though that was a great ending. And so just I'm going to draw everyone's attention to there's a QA icon. I think it's at the bottom of your screens, and you can type in any question that you'd like to address to either Dr. Bokani, to Paul, to Tom. So I'll just give this as we're on time, so well done everyone. I'll just give us a couple of minutes to see what questions come up, and then we can wrap this up. Okay, just another one question that came up now, and this could go to anyone, like either Dr. Bokani or Paul. Do you think patients are going to be expecting their radiologists to be using AI? Do you think this is something that you can foresee in the future?
I can take this one, Paul, if you don't mind. Yes, I think so, because there is now awareness of artificial intelligence. Basically, artificial intelligence is surrounding us everywhere. We can't live without mobile phones. We can't live without sat-nav or navigation systems and other things. And so I think there's an expectation in the community as well. This technology has to infiltrate into healthcare and into health services. And from the discussions I have with GPs and other people in the community, yes, there is an expectation, and it will be expected from us to be utilizing the technology, because as we mentioned and as we illustrated, it's impacting patient outcomes and patient lives in a positive way, I mean, luckily. So the answer is yes. We should be embracing the technology, and I think the community is expecting us to utilize it as well.
Thank you, Dr. Bokani. I have some housekeeping questions here. Yes, we will be sharing the recording following, so everyone who's registered and attended will get the recording. And there's also a question about the publications that we mentioned in the beginning. Yes, I will share this with the specific person who asked for this. That's not a problem. Okay, so we're about to wrap up. I really appreciate everyone's time. Both, oh wait, one more has come up. Okay, so and I guess this is to you, Dr. Bokani. Have there been many examples of false positives? And then maybe the continued question would go to probably Tom. Does Aidoc have the ability to learn from these?
Sure, I will answer the first part of this question. Yes, there were a few examples of false positives, and I think, as Paul mentioned, there is a wide range of variability in the scanners we use across the entire business. And depending on some artifacts, and I will mention a few of them, for example, the skull-based artifacts in CT brains, Aidoc could pick up an artifact and think this is a positive finding, and other false positives will be, for example, the dense aspect of blood in one of the dural venous sinuses. This could be interpreted as being a positive as well. But generally speaking, the performance has been really very good when it comes to CT brain, and pulmonary embolism has been exceptionally good, and especially in the detection of tiny emboli in the peripheral circulation. Cspine is doing good as well, although in the beginning, and again, because we deal with different populations and of patients, there will be a fair bit of osteoarthritis and other findings that could impact the outcome on Aidoc. But as we progress, and I will put this to Tom, perhaps Aidoc can improve its performance. I think Tom can elaborate on that part.
Yeah, we get asked, that's an interesting question. Thank you, Dr. Bokani. And the question about AI learning, and does AI specifically have the ability to learn from false positives and again, from performance out in a clinical setting? Tom, can you add some clarity as how that actually works from an...
Of course. And thank you, Dr. Bokani. And I'm glad this question was asked, and I think there's nothing to fear, right? Because we despite putting a lot of effort and being very accurate, we're not perfect, and we do have false positives, such as the examples that Dr. Bokani shared. I think that at the end of the day, the real evaluation of how accuracy impacts our value and what is the right threshold, or I'd say the minimal threshold for having a useful product, is twofold. One, is there evidence of AI being accurate enough in that very small percentage of findings or cases that a radiologist might overlook, can AI capture a portion of those and really save a radiologist false negative? And I think some of the examples Dr. Bokani indicate that that's the current status. And the second part is, even if it's accurate and prevents misses, is the balance correct in that it doesn't create too many false positives and becomes a disturbance? And from our perspective, I think the ultimate ruling on whether we're at that state or not is the level of engagement. And Dr. Bokani shared how nearly all his radiologists engaged with the software on nearly all of the cases. I think it was 99%. And from my perspective, I think that's the ultimate evidence that it's useful and worth it, because nobody's forcing his radiologist to use it. And if they would have felt on a personal basis that it has too many false positives and isn't generating enough value to them specifically, they would have just ignored it or disabled it or turned it off. They have the ability to do so. So I think that's the ultimate test. Now, in terms of how we utilize feedback from our partners, such as what we just heard from Dr. Bokani, it is very helpful for us. From a regulatory perspective, AI at this point cannot be continuously changing, meaning we freeze our software at a certain point, and that is what's tested by the regulatory authorities. And we can't change that until we go through an additional process with the agencies and only then release the next version. So that's what it looks like from an actual product evolution perspective. Now, behind the scenes in our labs, we do continuously work on improving our products for that next version. And the way we do so is we also take into account feedback we get from different users and institutions using our software, because they really represent all of the world. Dr. Bokani mentioned Paul mentioned a 16-slice scanner, or a cutting-edge brand new scanner. There are different clinical settings, types of trauma centers, imaging centers, et cetera, et cetera. So as we expand, we get more types of feedback and data points that help us steer our training and our improvements to address those specific, let's call it, areas for improvement. And if, for example, Dr. Bokani or any user refers us to a frequent false positive on a streak artifact in a specific type of scanner or situation, then in our internal training sets, we will make sure that we add more cases with such scenarios and clearly identify them as negative for the neural network to learn and understand that that is not a hemorrhage, for example. So really, it's not required. We continue our QA processes also independently, but it does add value to have such an engaged partner that also goes out of their way to give us additional feedback.
Thank you, Tom. There's one more question. That's actually the last one, where there was a mention of that Aidoc is evaluating CT images, but what scope do you think will this application work in plain film? What do you maybe give us sort of? Yeah.
So we talked about our FDA cleared products. However, the process, the regulatory approval process is always going to be after our development and our clinical trials of various types of AI products. So I can share some plain film related solutions of ours. They're not yet FDA cleared, but they're on their way. And by the way, I keep referring to FDA. What I'm saying is also true for the various regulatory agencies. Our upcoming, without giving away too much, I'd say our upcoming X-ray products are going to include, from a chest perspective, pneumothorax and rib fractures. as well as extremities for fractures and hip and pelvis fractures. So stay tuned, and maybe in our next webinar we can share more information about that. Now, it's also important to clarify that it's not just a question about of the modalities, it's also a question of the manufacturers and the PACS vendors, and everything we develop is from the get-go is developed to work out of the box, and it's all agnostic. So it works with the different PACS vendors and the different modality manufacturers. It's all agnostic.
Thank you, Tom. So we're about to wrap up. I'm happy to see that the audience did have questions and that it was a nice interactive session. Any parting thoughts from anyone? Dr. Bokani, Paul, before we all say goodbye?
No, I guess from my side, if you have any questions that we haven't answered or areas that you feel that we haven't addressed, you're more than welcome to contact us directly.
Perfect.
Same here. Thank you everyone for joining us on this quite exciting webinar. And again, the last message from me would be the technology is here. It's not the future. It's now. We're living in it, and we're using it. And I would encourage everyone really to jump on this interesting and exciting development in the way we practice radiology and medicine in general. Thank you.
Thank you, everyone, and thank you for helping me with my technical issues on the presentation perspective. I appreciate everyone's time with us today. Yes, a recording will be sent to everyone following, and please approach us if you have any additional questions. So good evening, good afternoon, good night for all of you, and hope to be able to meet again soon. Thank you, everyone, and goodbye.
Bye-bye.
Thanks. Bye-bye.